Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 232 of our pharmacotherapy series, which majors in respiratory tract infections. S.A.R. is a 50-year-old man presenting with a chief complaint of cough. His symptoms have persisted for 8 days, and he now produces yellow sputum with each cough. He has had no recent illnesses, however, his 14-year-old son in high school has experienced recent mild colds. S.A.R. denies nausea, vomiting, or fever and chills. A review of symptoms reveals fatigue and difficulty sleeping because of cough. Past medical history includes hypertension managed with lisinopril and hyperlipidemia, for which he takes atorvastatin. He also takes low-dose aspirin for stroke prevention. Vital signs indicate a temperature of 37.1 degrees Celsius, heart rate of 70 beats per minute, blood pressure of 130 systolic 70 diastolic, and respiratory rate of 18 breaths per minute with accompanying oxygen saturation of 98% on room air. His physical examination is positive for coarse breath sounds that clear with coughing, but it is otherwise normal. So my question to you is, what signs and symptoms in S.A.R. are consistent with acute bronchitis? Persistent cough in the absence of other symptoms including fever or myalgia is typical with acute bronchitis. Cough can last up to 3 weeks and is usually self-limited. The typical duration of symptoms in acute bronchitis is 5 to 14 days. Pneumonia must be ruled out, however, normal oxygen saturation and lack of focal signs on pulmonary physical examination makes this diagnosis less likely. Sputum production is common, although not present in all cases of acute bronchitis. Symptoms can be present at night, contributing to S.A.R.'s symptoms of fatigue. My next question to you reads, what are the most likely causes of S.A.R.'s case of acute bronchitis? The causative agent for acute bronchitis is identified in a minority of cases, however, when pathogens are isolated, they are usually of viral etiology. A limited number of bacterial pathogens are associated with acute bronchitis and should primarily be considered in patients with underlying COPD, mechanical ventilation, that is tracheobronchitis, or in cases of outbreaks and exposures, e.g., Bordetella pertussis. Sick contacts, duration of incubation, for 2 to 7 days for viruses versus weeks for atypical bacteria, and previous exposures should be considered when determining the etiologic agent responsible for acute bronchitis. Specific symptoms reveal infection caused by specific pathogens, such as an inspiratory whoop and post-tussive emesis caused by Bordetella pertussis, pharyngitis and cough lasting longer than 4 weeks caused by Mycoplasma pneumoniae, hoarseness with low-grade fever caused by Chlamydophila pneumoniae, or cough with fever and myalgias caused by influenza. Given S.A.R.'s lack of sick contacts with bacterial infections, his son's recent colds are most likely of viral etiology, time course of present illness, and absence of symptoms suggestive of influenza. A viral etiology other than influenza is most likely to be the cause of his symptoms. My next question to you reads, should S.A.R. be provided an antimicrobial agent for his acute bronchitis? Antibiotics have not been shown to substantially reduce the duration of illness in acute bronchitis. Thus, guidelines recommend against the routine use of antimicrobial therapy for acute bronchitis. Despite these recommendations, antimicrobials are frequently prescribed for this condition. Inappropriate use of antimicrobial therapy is a public health concern because it may lead to adverse events and antimicrobial resistance. One exception to avoidance of antimicrobial therapy in acute bronchitis is if Bordetella pertussis infection, as in whooping cough, is suspected. In these cases, antibiotic therapy with a macrolide antibiotic is recommended, and patients should remain in isolation for the first 5 days of treatment to prevent disease transmission. In S.A.R.'s case, no antimicrobial agent is warranted. The next question reads, should a sputum culture be obtained from S.A.R.? What other diagnostics should be considered? Obtaining a sputum sample for culture to determine the presence of the causative agent or diagnostic screening for atypical pathogens is not routinely indicated for acute bronchitis. The rationale is that most of the identified pathogens have no specific treatment, especially viral illnesses, and the isolated organisms often are not true pathogens. Diagnostic screening, however, should be performed during influenza season or during outbreaks of Bordetella pertussis or other atypical pathogens for infection control purposes. The use of biomarkers for the diagnosis of bacterial infection, such as procalcitonin or C-reactive protein, may decrease inappropriate antimicrobial use in acute bronchitis, but their widespread use cannot be recommended at this time. My next question reads, what symptom-guided therapies should be offered to S.A.R.? Symptom-guided therapies include the use of inhaled beta agonists, that is albuterol, for shortness of breath, particularly in patients with underlying reactive airway disease, inhaled or systemic steroids for persistent cough, non-steroidal anti-inflammatory drugs abbreviated as NSAIDs, aspirin, or acetaminophen to alleviate myalgias or fever, or antihistamines like chlorpheniramine, antitussives, such as codeine, dextromethorphan, or benzonatate, or mucolytics, such as guaifenesin, for cough. These symptom-guided treatments, however, are not backed by strong evidence demonstrating a clear benefit in patients with acute bronchitis. As such, each of these treatments should be approached with an appropriate consideration of the balance between perceived benefit and risk of adverse events. Given S.A.R.'s troublesome cough that has kept him up at night, a trial of an antitussive such as dextromethorphan is a reasonable first option. NSAIDs should be avoided given his concurrent aspirin use and lack of clear indication. An inhaled beta agonist or steroid is also not necessary at this time. The next questions read, should a chest radiograph be ordered for S.A.R.? What other illnesses may be considered as the cause of his symptoms? It is important to distinguish acute bronchitis from pneumonia with chest radiograph or other imaging tests when fever, tachycardia, tachypnea, physical examination findings such as egophony or RALS, or hypoxemia or mental status changes, especially in the elderly, are present. Clinical differentiation of acute bronchitis from acute exacerbation of COPD, postnasal drip, gastroesophageal reflux disorder, abbreviated as GERD, and asthma must also be made. In S.A.R's case, no signs of pneumonia are seen on physical examination or on reviewing symptomatology. Therefore, no chest radiograph is warranted. Frequent symptoms over time or risk factors for COPD would warrant an investigation for chronic bronchitis. Wheezing or frequent acute bronchitis outbreaks and GERD symptoms would guide evaluations for asthma or gastrointestinal disorders, respectively. My next question to you reads, what education would you provide to S.A.R to dissuade his perceived need for an antibiotic? An evaluation of S.A.R's expectations for therapy is important to alleviate concerns about the decision not to prescribe antimicrobials. Overuse of antibiotics in acute bronchitis is often driven by either prescriber knowledge or patient request. Communication is key with each patient to provide insight into the potential causative agents of acute bronchitis, the natural course of the disease, the role of symptomatic relief, and reasons for avoiding prescriptions for antibiotics. T.S.H is an 81-year-old white woman presenting to the emergency department because, in her own words, she cannot catch her breath. At baseline she is on 4 liters of oxygen continuously via nasal cannula. However, during the last week she has experienced worsening dyspnea necessitating help with daily activities including bathing and feeding. Her daughter had contacted T.S.H's primary care physician who directed the patient to the emergency department when T.S.H seemed out of it and was difficult to arouse. T.S.H's daughter indicates that T.S.H has been having a cold, with increased sputum that is more yellow than in the past with frequent coughing spells. Past medical history is significant for very severe COPD, atrial fibrillation, depression, obstructive sleep apnea, morbid obesity, and a left humerus fracture. No medication allergies are noted. Her medications at home include aspirin 81 mg orally daily, citalopram 20 mg orally daily, diltiazem extended-release capsule 240 mg orally daily, salmeterol with fluticasone dry powdered inhaler 50/250 dosed at 1 puff twice daily, and albuterol inhaler 4 puffs every 6 hours as needed for shortness of breath. Her social history is significant for a greater than 80-pack-year history of cigarette smoking, but she quit 4 to 5 years ago. In the emergency department she was afebrile, heart rate was 96 beats per minute, respiratory rate was 23 breaths per minute, blood pressure was 135 systolic 75 diastolic, and oxygen saturation was 60% on 4 liters of oxygen. T.S.H is in some distress, alert and oriented ×2, and is using accessory muscles for breathing. Initial physical examination was significant for distant breath sounds and decreased air movement bilaterally, a noted absence of lower extremity edema, and an irregular heartbeat. Her laboratory findings are as follows. Regarding the arterial blood gases, pH is 7.34, pCO2 is 60 mm of mercury, PO2 is 72 mm of mercury. WBC is 9.8 times 10 power 3 per microliter, with neutrophils accounting for 71%. Hemoglobin is 12 grams per deciliter. Her platelet count is 319 times 10 power 3 per microliter. She has sodium levels of 135 millimoles per liter, potassium of 3.7 millimoles per liter, chloride of 91 millimoles per liter, and bicarbonate of 39 millimoles per liter. Her blood urea nitrogen, abbreviated as BUN, is 15 milligrams per deciliter. She has a serum creatinine of 1.21 mg per deciliter and glucose of 104 mg per deciliter. Her brain natriuretic peptide is 66 picograms per milliliter. Troponin levels are less than 0.07 nanograms per milliliter. Thyrotropin is 1.63 micro-international units per milliliter. Chest radiograph indicated small pleural effusions, but it was otherwise negative for infiltrates or consolidation. An electrocardiogram indicated the presence of atrial fibrillation. Pulmonary function tests, obtained 1 year ago, indicated an FEV1 to forced vital capacity ratio of 0.39 and an FEV1 of 37% predicted. My question to you reads: how would you stage the severity of this exacerbation for T.S.H.? T.S.H. has several risk factors for a poor outcome, including the presence of atrial fibrillation and severe COPD defined by her home oxygen requirement and low baseline FEV1. Clinical signs and symptoms consistent with a severe exacerbation include the use of accessory respiratory muscles, paradoxical chest wall movements, worsening or new cyanosis, peripheral edema, hemodynamic compromise, signs of right heart failure, and alterations in mental status. T.S.H. has two of these factors, that is reduced alertness and use of accessory muscles. The next question reads: which therapies should be made available to T.S.H. to alleviate her shortness of breath? Supplemental oxygen to alleviate hypoxemia is a foundation of treatment for acute exacerbation of COPD. Controlled provision of oxygen should be implemented to provide an oxygen saturation of greater than 90% or a PaO2 of greater than 60 mm of mercury. Hypoxia that is not easily reversible warrants further examination for venous thromboembolism, pneumonia, or other causes. A repeat arterial blood gas should be obtained within 1 hour of initiation of supplemental oxygen to assess for carbon dioxide retention or acidosis. The use of short-acting bronchodilators should be initiated promptly in all patients with acute exacerbation of COPD. Beta agonists, such as albuterol, with or without an anticholinergic agent such as ipratropium, are the preferred agents. If the patient does not respond, a methylxanthane such as theophylline or aminophylline may be considered as second-line therapy. There is no role for long-acting bronchodilators in acute exacerbation of COPD at this time. My next question to you reads: does T.S.H. need to be treated with antimicrobial therapy? The cardinal symptoms of acute exacerbation of COPD include increases in sputum purulence, sputum volume, and dyspnea. The use of cardinal symptoms as a method of staging acute exacerbation of COPD severity has been used in several prospective studies and is recommended in the GOLD guidelines. Experts advocate for the use of antibiotics for acute exacerbation of COPD, particularly when 2 or 3 cardinal symptoms are present. Specifically, the GOLD guidelines recommend antibiotics for patients with 3 cardinal symptoms, that is increased dyspnea, increased sputum volume, and increased sputum purulence, when 2 cardinal symptoms are present if increased sputum purulence is one of the symptoms, or in all patients requiring mechanical ventilation for their acute exacerbation of COPD. T.S.H. is exhibiting all 3 of the cardinal symptoms and therefore should receive antibiotics. Likely benefits would be enhanced treatment success, prevention of relapse, decreased risk for rehospitalization, improvement in pulmonary function, and reduction of the severity of her exacerbation. My next questions to you read, which antimicrobial agent should be selected for treating T.S.H? What duration of treatment would be recommended? Given T.S.H's history, diminished mental status, and risk factors for poor outcomes, intravenous administration seems appropriate for the initial antibiotic administration. Potential risk factors for Pseudomonas aeruginosa should be evaluated. If T.S.H demonstrates risk factors for Pseudomonas aeruginosa, an anti-pseudomonal beta-lactam, such as cefepime, would be an appropriate initial agent. If no risk factors for Pseudomonas aeruginosa exist, a beta-lactam, beta-lactamase inhibitor such as ampicillin, sulbactam, a third-generation cephalosporin such as ceftriaxone, or a respiratory fluoroquinolone such as moxifloxacin or levofloxacin should be selected. All these therapies are active against drug-resistant Streptococcus pneumoniae, abbreviated as DRSP. If T.S.H improves on one of these parenteral agents and is ready for discharge, T.S.H could transition to an oral respiratory fluoroquinolone or high doses of amoxicillin, clavulanate. Another important consideration for initial selection of antimicrobials is an evaluation of antibiotic history. Alternative antimicrobials from another class should be considered if patients have been previously treated in the last 3 months. Additionally, if no improvements in symptoms occur within 72 hours, consider obtaining a sputum sample for directed therapy. The duration of treatment of antibiotics for acute exacerbation of COPD suffers from lack of solid evidence-based recommendation. Given findings from CB investigations, a duration of 5 to 10 days has been suggested, but this is an area in need of further research. My next questions to you read, should T.S.H be treated with corticosteroids? If so, which dose and duration would be selected? In the setting of acute exacerbation of COPD, systemic corticosteroids help to improve lung function, shorten recovery time, and prevent relapses. Based on available evidence, the GOLD guidelines recommend a corticosteroid regimen of 40 mg per day of prednisone for 5 days in patients with acute exacerbation of COPD. This regimen would be appropriate for T.S.H, although an equivalent intravenous regimen could be considered if she was not able to take an oral regimen. Higher doses and longer durations of therapy have not been found to confer a clinical advantage, and intravenous and oral regimens are considered equally effective. In those patients receiving more than 3 weeks of steroids or multiple course of steroids in the previous months, tapering the dose should be considered. Although it is more expensive, nebulized budesonide may be considered as an alternative to oral corticosteroids for treatment of acute exacerbation of COPD. The next question reads, what factors should be assessed for T.S.H during her hospitalization, and what follow-up should be planned to help assure she recovers fully and is not readmitted for COPD? Hospitalized patients with acute exacerbation of COPD should both be optimally treated, and their COPD management be assessed to decrease the likelihood of readmission. T.S.H's baseline COPD medications should be examined and adjusted based on disease severity. Additionally, an assessment of her understanding of the role of medications, that is maintenance therapy versus rescue medications, ability to use inhalers correctly, access to her prescribed medications, and discussions regarding pulmonary rehabilitation should take place. Consideration for pharmacologic venous thromboembolism prophylaxis should also be made in this high-risk population. My last question to you reads, which vaccines should be considered for T.S.H as part of her COPD management? Vaccination records for influenza and Streptococcus pneumoniae should be evaluated in T.S.H. Annual influenza vaccination is recommended for all patients equal to or above the age of 6 months with COPD, and it has been shown to reduce the risk of acute exacerbation of COPD. Vaccination against Streptococcus pneumoniae with the 23-valent polysaccharide vaccine is recommended for patients equal to or above the age of 19 years old with COPD. Unlike the influenza vaccine, however, vaccination against Streptococcus pneumoniae has not been clearly linked with a reduced risk of acute exacerbation of COPD. The pneumococcal vaccine is recommended by guidelines, however, as part of the overall health plan of the patient. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 233.